I'm very pleased to be talking about early antiretroviral treatment, or ART, and particularly does early antiretroviral treatment influence clinical outcomes. To move this forward, I do. Move forward, mouse movement. No. That's right. Thank you. The pediatric HIV research community has been somewhat ahead of the curve in terms of addressing the really important clinical question of when to start ART in children. This question was answered in 2008 with the clinical trial known as SHARE, which randomized children to either immediate ART as soon as diagnosed or deferred ART at a time that they met clinical criteria to start ART. And this clinical trial came to the very clear conclusion: start treatment right away, as soon as you can. And in answer to the question, why should you start treatment right away as soon as you can, is that there was a clear benefit for mortality and for the reduction of very severe clinical endpoints. But on average, the children starting treatment in this trial early, immediately as soon as diagnosed, were an average of 7.4 weeks of age. So certainly very young, but not yet in the neonatal period. Five years later, the question of when to start ART emerged again with the Mississippi baby. In this case, the Mississippi baby started treatment within 30 hours of birth. So we're moving the time frame now from talking about weeks of time to talking about hours from birth. So early is being shifted in terms of the time frame. Also, in answer to the question of why should you hurry up and start treatment so quickly, so right away, interest has shifted away from clinical endpoints to the possibility that starting so early can actually facilitate HIV remission. The tremendous success of antiretrovirals make us ask the question, can antiretrovirals do everything? We're all very familiar with the tremendous success of antiretrovirals for prevention of mother-to-child transmission. We also know about the success of treatment, which has changed a rapidly fatal infection into a manageable chronic condition. But can antiretrovirals, if given early enough, also lead to cure? So I'd like to digress a little bit to talk about some pragmatic definitions. So when we talk about HIV cure, essentially what we mean is that people would come off ART, they would be able to control virus to essentially undetectable levels, and this would be forever. When we talk about HIV remission, we generally mean that you come off ART, you're able to control virus somewhat, perhaps not to undetectable levels, but to low levels, and this is for some long period of time, probably not forever. And then there's down the rung a little bit further, we've got what we call elite controllers, and Professor Goldup has promised to explain to you what the difference between an elite controller and HIV remission is, so he's coming after me and he'll explain all of that to you. But I'm going to be focusing on what I call well-treated, which is certainly a long way from HIV remission or HIV cure. And by well-treated, what I refer to is being alive, on treatment, and virally suppressed. So the clinical endpoints that I'm going to be looking at in this presentation today is survival, so being alive, which first requires identification, which means diagnosis, enrollment into care, initiation of ART, and then retention on ART for a reasonably long period of time. And then once on ART, achievement of viral suppression and sustaining this viral suppression. So to start with survival, I assembled what I was able to find on mortality in very early treated children. And so these are the 5 reports that I was able to locate on neonates. So these are infants under 28 days of life where there's reports on mortality. And the height of the bar shows you how many are in the denominator of these cohorts. And so you'll see they're rather small in terms of number. So from our study LEOPARD in Johannesburg, we reported at CROI last year, out of the first 33 neonates who had started treatment within 48 hours of life, 3 of the 33 had died in the first 3 months of life. Roger Shapiro reported at CROI earlier this year on the Botswana cohort. There were 37 who had started in the first few days of life in Botswana. 1 out of the 37 has died so far. Not all of the cohort has been followed for very long. From a report from Cape Town on 22 neonates initiated on treatment, there was 1 reported death out of the 22. And then the Canadian cohort, which identified 12 of neonates starting treatment within 72 hours of birth. There were no deaths out of these 12. And in Ellen Chadwick's presentation from this meeting last year from P1115, out of the first 30 neonates who had started treatment within 48 hours of life in that cohort, there had been no reported deaths. So these data are very hard to interpret given the very small denominators. And there's also challenges in terms of knowing how representative these cohorts of neonates actually are. Because for crucial in terms of understanding early treatment is knowing how these cohorts are assembled in terms of how they're identified and how we know, what does it mean to be early? How did you even get into this cohort to begin with? Because you can only start ART very early if diagnosis is very early. So in the LEOPARD study, we concluded that the only way it would be possible for us to start treatment very early is if we had on-site diagnostic testing. So we put in place an on-site diagnostic testing program with HIV Expert, which is a point-of-care test, a point-of-care PCR, and this was done in addition in parallel with the routine lab-based PCR. But we were not able to achieve 100% coverage with the on-site testing, and so this allowed us to compare those children who could be identified with the on-site testing and therefore started on treatment somewhat earlier to those children who were missed by the on-site testing program and who therefore had to be recalled before we could start them on treatment. So with putting in place an on-site diagnostic testing program, we could certainly accomplish earlier initiation of ART. So I'm dividing our cohort here into 2. On the left-hand side are those where we were not able to reach these children with the on-site diagnostic program. And so these children were only tested with the routine laboratory-based testing program and therefore had to be recalled, they had to be identified, had to come back to the site in order to initiate ART. And on the right-hand side is those who were co-tested with the on-site testing program, and these children could be initiated on treatment before discharge after delivery. And in the bars are the numbers of children who are starting treatment at different days of age, going 0 through 14 days after birth. And then in pink at the end is those who are starting treatment at 14 plus days, so 15 days and more. And you'll see that even those who needed to be recalled, almost all of them could be started in the first 2 weeks of life, and about half within a week. So that's pretty rapid in terms of bringing people back. But it was only in the group who were treated with the on-site, had opportunity to be exposed to the on-site testing that the majority could start within 48 hours of life. We were also encouraged that there was somewhat greater proportion initiating ART and surviving in those who had the opportunity to be tested with the on-site testing. So in the cohort of confirmed infected children, 82% of those could be initiated on ART if they were diagnosed with the on-site testing program, whereas only about 70% of those who were missed by the on-site testing program could be recalled, located, and initiated on ART. So there was a difference here, and there seemed also to be a slight excess mortality in the group who had been missed by the on-site testing program, and there was a larger proportion lost to follow-up. So these are the ones who either declined to return to the hospital for follow-up or could not be located in terms of returning to receive their results. But we were concerned that initiating antiretroviral treatment immediately post-delivery may not be the best time for the mother. This may not be the best time for her to comprehend all of this rather complex information about all the many issues involved in treating her child. And so we were concerned about long-term retention in care and whether, in fact, there might be adverse consequences of initiating antiretroviral treatment so early. So we looked at 6 months later in terms of this same group who was still retained in care. And here we were somewhat reassured, although the retention of this entire cohort through even to 6 months has now declined to just about 2/3, so about a third have been lost, either through loss to follow-up or mortality by this point, that there was no adverse effect, so there's not worse outcomes in those who had been initiated on treatment right away within the first 48 hours. However, we are seeing slightly more deaths, so the additional deaths that we're adding on between initiation of ART and 6 months do occur more frequently in the group who have had opportunity to have the on-site diagnostic testing program. So those are the darker shade triangles shown in the pie there. So we are kind of getting some catch-up loss to follow-up and mortality in that group. Looking then within the group of confirmed HIV-infected infants in the study, so this is putting the two groups back together, we observed a surprisingly good profile of pre-ART viral loads in these confirmed HIV-infected neonates. So usually when we have previously conducted studies at the site of infants initiating ART, the majority had viral loads that were very high. And when we first started doing these studies, our assay that we were using only quantified up to 750,000 copies, and the majority of the infants that we started on treatment all fell above this threshold. In this cohort of early identified neonates, only 12% of the neonates had viral loads that were above 750,000. The median was in the 30,000 copies range, and 20% had a viral load less than 1,000 copies pre-ART. And Jane Millar from KZN is going to be giving more detail on the KZN cohort in a session later today. We were also able to demonstrate that looking at the infant viral loads, these infant viral loads were in fact correlated with the mother's status. So if you look at the panel in the right, the blue curve is plotting the distribution of infant viral loads when the mothers are on ART and virally suppressed. And then the red and the green bars are showing the infant viral load when the mother is not on ART or who started ART late, and her viral load is above 1,000 copies. So clearly the mother's and the child's viral loads are correlated. Now, given this very promising profile, we thought we should certainly see a very rapid decline in viral load in these neonates. And this is certainly what we saw when we did a review of the literature looking at the rates of viral decline in neonates initiating ART. We were able to assemble 13 neonates who initiated treatment, and we plotted their viral loads, and we certainly see a very rapid decline in viral load over time. However, one has to ask the question, how generalizable are these 13 cases that are published, and is this selection bias? Are people reporting on their best cases and leaving out those who do not do so well? So we looked within the first 79 confirmed HIV-infected neonates in LEOPARD, and we're restricting to those who started within the first 2 weeks of life. And then we're plotting here what proportion achieve viral load less than 50 copies by 24 weeks of age. And only 60.7% of those who initiated treatment within the first 2 weeks of life had achieved a viral load less than 50 by 6 months. If we then look among this group who sustain a viral load, and we can use either a strict or a liberal definition, and by a liberal definition we mean that they have no confirmed viral rebound, so you've got to have 2 to count as a rebound, then 43.2% are virally suppressed within a year, sustained viral suppression within a year, and 26.5% meet a strict definition of virally suppressed. But the assays we are using quantify down to below 50 copies. In fact, they quantify down to 20 copies. And then if the value is below 20 copies but still quantifiable, the assay reports that out. And if there is no virus detected, the assay reports this out as target not detected. So we can look at stricter definitions of what counts as viral suppression. And if we look at these stricter definitions of viral suppression, only 37.8% achieve target not detected by 24 weeks after initiating ART. And if we look at our strict and our liberal definitions of sustained, 21.8% are sustaining a target not detected value over time, and only 13.9% are sustaining this in a very strict way. So I think there's two somewhat divergent conclusions that you can reach from these data. Firstly is that the rate of viral suppression by 6 months is suboptimal. We would expect a higher proportion to be virally suppressed. We would expect viral suppression to be more rapid by this time, and we would certainly expect the rates of sustained viral suppression to be better than this. So this is certainly suboptimal in terms of rates of viral control. But there's a divergent point of view, is that what we're also seeing is that there's a subgroup within this overall cohort who do exceptionally well. And I'd like to draw your attention to the subgroup who achieve target not detected, and particularly the subgroup of the subgroup who sustain target not detected over time. And so within these subgroups, very large proportions of these revert to being diagnostic PCR negative. So in fact, if we look at the strictest group, those who sustain target not detected over time, almost 80% of these are reverting to being PCR negative. If we express this as a rate in the entire cohort, it's 15.4% of the entire cohort are reverting to being DNA PCR negative by 24 weeks after initiating ART. And this rises to 20% of the cohort if we take it out to 72 weeks after initiating ART. But the question still remains, how generalizable are these findings? And unfortunately, there are very few data to compare our findings to. From the Botswana cohort reported at CROI, there were 9 cases reported. All of these were virally suppressed within the time frame presented, but 3 of them rebounded in terms of the time frame that was presented. And in the published literature, again, very small numbers from Cape Town and from Canada, very difficult to interpret, giving high rates of loss to follow-up. So in summary, early ART does not prevent all mortality. Engagement in care at an early age is difficult, but does not appear to have an adverse effect on later retention. Infant pre-ART viral load is generally low and is related to maternal ART status and maternal viral load status. And despite this very favorable prognostic profile of infants when they start ART, viral suppression rates are slower than we would desire, and the rates of sustained viral suppression over time are suboptimal in this group. But on a more optimistic note, there is a subgroup who have a very excellent response. So I think in conclusion, there remains an urgent need for clinical research to identify strategies on how to effectively treat these infants, because we have not yet been able to accomplish what we consider the minimum standard for being well treated on ART. While we certainly wait in anticipation about the possibility that some of these excellent controllers may indeed be able to achieve HIV remission, we need to find ways that the majority can at least be said to be well treated, by which we mean alive, in care, and virally suppressed. So treating them early is not enough. We need to find better strategies that we can also consider them well treated early. So I'd like to thank NICHD and NIAID who has supported our work. I'd like to thank all the individuals who helped me with assembling this presentation, and I'd like to thank in particular the LEOPARD team in Johannesburg who's been working on the study over many years, and particularly Renata Strelau, who leads the team in South Africa. Thank you.